Good afternoon, everyone. Good afternoon, everyone. Our first speaker for today is a graduate of Bachelor of Science in Applied Physics, major in Health Physics from University of the Philippines, Manila. During his undergraduate years, he was a DOST scholar and a National Institute of Health Research grantee. He was a data consultant at Asian Development Bank with the research of results of malaria elimination and control of communicable disease threats in Asia and the Pacific. Our speaker was also a consultant at the United Nations Children's Funds, Philippines, with the research of reducing inequities on information for urban poor communities. Also, our speaker was an epidemiologic consultant at World Health Organization Vietnam Health Dashboard. He is a Master of Science in Epidemiology program qualifier at the London School of Hygiene and Tropical Medicine. He is a candidate for Master of Public Health at the University of the Philippines, Manila. Currently, our first speaker for today's webinar is a research assistant National and Western Pacific Region COVID-19 response. It is my great pleasure and honor to introduce our first speaker, Mr. John Carlo Lorenzo.
Hello, everyone. Hello, good afternoon.
Good afternoon, sir. Good afternoon po.
Hi. Can I start?
Yes, sir.
All
Thank
right.
you.
Let me just share my screen. Hi, good afternoon, everyone. So let me just reintroduce myself. So I am Carlo Lorenzo, Master of Public Health candidate, just a candidate, not yet a graduate at the University of the Philippines, Manila. I am not a research assistant. I am a epidemiologic surveillance officer at the World Health Organization Western Pacific Regional Office, and also a data analyst at the Asian Development Bank. So though I think yung mga na-present to work kanina is 2018 pa. So those are information were a bit not accurate. So this presentation, although all the analyses, all the interpretations that you can find in this presentation does not reflect the interpretation and analysis of the organizations that I am affiliated with. So this is an independent analysis. This is an independent presentation for this afternoon and for this event. And thank you for inviting me. Let me start. So let's start with the points of discussions. First, I'd like to briefly discuss what is epidemiology, because we've been hearing epidemiologic terms and epidemiology, but we're not really sure what is epidemiology. And also, I'd like to discuss the current progress of COVID-19 in the Philippines. Next is I'd like to clarify some of the epidemiological terms such as mass testing, flattening the curve, mass recovery, what is R naught or RT, what is case doubling time. So we'd like to touch on that later. And I'd like to provide basic and critical analysis of the DOH data, not DOH, sorry. That's DOH data, especially the case bulletin that they release every day and every week. And a little bit on exploring the possible use of epidemiologic data in public health, especially in policy and intervention making. So what is epidemiology, really? So epidemiology can be associated with public health and preventive medicine. This is more on prevention of disease, not curing of disease. So ayaw natin na mag-progress yung mga tao doon sa disease. Kaya po merong epidemiology at kaya po merong public health. So it is a discipline concerned with the distribution and determinants of health, diseases, and health phenomena in specific population at a given point in time. So when we say distribution po, this is more on the composition of the population. So sino yung mas affected, ilan yung babaeng na apektuhan, ilan yung lalaking affected, ilan yung senior citizens na mas naapektuhan po. And when we say determinants, this is more on finding the risk factors, finding the causative agents. Are there 2 or more factors para mag-progress sila dun sa disease? Is there any interaction among these risk factors para makapag-progress po sila dun sa disease? So for the determinants, it's more on the analytical part of epidemiology. And then we have to specify the population and specify the point in time. So for example, the epidemiology of, for example, there's COVID-19 now, right? Just in case magkaroon po ng COVID-19 sa 2040, we cannot compare the epidemiology of COVID-19 in 2020 to 2040. So basically, epidemiology is concerned with the things that happens to people. So hindi lang po sakit, pwede po yung any health outcomes po, pwedeng disability, pwedeng accidents, pwedeng protective risk, protective factors, among others. So what are the functions of epidemiology? So it is to describe the health status of the population. It also would like to explain the cause of disease, like the causal factors that I described a while ago, and to predict the occurrence of diseases. So with these evidences na nakikita po natin sa epidemiology, we can predict kung paano po we can predict yung pwede pong yung epi curve, di ba? We can predict po kung ilan yung may infect the following days or the following month, kagaya po ng ginagawa ng UP research team. And ultimately, we really want to control the spread of diseases. So the goal of epidemiology is to improve the understanding of natural history of disease and factors that influence the distribution, and to develop programs and interventions to address health events. So by combining these two bullet points, ultimately, ma-achieve po natin yung last point, which is to prevent and to control negative health events or diseases. So I'd like to touch on the latest epidemiological data of COVID-19 in the Philippines. So all data that I will present ay galing po sa Department of Health Bulletin Board, COVID Bulletin. So if mas gusto po natin maintindihan yung current data ng Philippines, pwede po natin i-visit yung DOH Facebook page. Okay, so this is our epidemic curve. So later we'll discuss what is an epidemic curve, but let me just show you that these are current epidemic curve as of August 24. You can see here, may mga nilagay po akong red. These are the important dates. So as we all know, on January 18, doon po yung first case natin ng COVID-19, which is an imported case. It is a Chinese national from China na po pumunta po dito sa Pilipinas. And then on February 2, ito po ay hindi lamang sa Pilipinas importanteng date. Ito po importante sa buong mundo because this is the first reported death outside China internationally. So sa Pilipinas po yung first death na outside China due to COVID-19. And then on March around March 6, yes, nagkaroon pa po ng 2 cases ng COVID-19, and these are locally transmitted cases. So dito po nahawa po sila doon po sa ating first case ng COVID-19. And then on March 12, dineclare po na ECQ ang certain parts of Manila. And then on March 17, nakadikit lang din po nitong red na to, dineclare na po yung ECQ and extend po yung ECQ sa buong Luzon. And then here, in-announce po na bumalik po tayo sa MECQ. And then for June 1, dineclare po ng ating authorities na babalik po tayo sa GCQ to reopen our economies. And then August 1, as requested by the frontliners to recalibrate our strategies to fight COVID-19. Bumalik po tayo sa MECQ, and on August 18, bumalik po tayo sa GCQ. So I can see a lot of people being confused with this ECQ, MECQ, GCQ. Sa Pilipinas lang ba ito nangyayari? Hindi po. Sa iba't ibang bansa din po, meron po silang tinatawag na stages of lockdown. Sa atin lang po, ganito po yung tawag. For example po sa Malaysia, they have MCO, Movement Control Order. Meron din po silang enhanced MCO. So that is enhanced movement control order. They have the recovery also, recovery movement control order. So sa iba't ibang bansa po, meron din po silang lockdown measures. So these are just the number of individual tested for COVID-19. As you can see here, tumataas po talaga yung atin pong testing capacities, di ba? Nagtetest po tayo mula po nung July hanggang ngayon, nagtetest po tayo ng around 30,000 samples or individuals para po sa ating COVID-19. Pero kahit po consistent yung ating testing, makikita po natin na yung nagpa-positive po for COVID-19, mas maintindihan po natin yan dito sa daily positivity rate. Pero makikita nyo po dito yung mga pula, ayan po yung mga nagpa-positive na cases or na test doon po sa tinest that day. So what is daily positivity rate? For example lang po, for today, meron pong 100 na iti-test for COVID-19 sa 100 sample. Sa 100 yon, 90 yung negative, 10 yung positive. Ibig sabihin po, merong 10% positivity rate for that day. Okay, so wag po tayong mga-confuse sa daily positivity rate. Meron din po tayong cumulative positivity rate. Yun po yung kino-compute, yung lahat ng nag-positive sa lahat ng tinest. So for the positivity rate, as you can see here on your left, our current positivity rate, I think this is cumulative, is 10.5%. So ibig sabihin po, sa 100 na iti-test, 10.5 po yung magpa-positive. Yun po yung ibig sabihin ng positivity rate. So for the latest statistics this is as of August 23. So we created this slide last August 23 kaya po hindi siya updated. So the currently total active cases is 55,000. The infected cases is 189,601. Our total recovered cases is 131,000. Unfortunately, less than 3,000 po yung namatay na po due to COVID-19. So let's go to the reports on clusters. So what are clusters? Ang clusters po ay dalawa o mas marami pang kaso ng COVID-19 or probable na cases ng COVID-19 na parang magkakasama. Parang malolocate po natin sila sa isang lugar. Pwede pong sa hospital, pwede pong sa grocery store, or pwede pong sa event, pwedeng sa manyanita. Sila po yung parang magkaka-aggregate. Ganun po. So meron na po tayong 1,302 na clusters, and I think more than 1,000 po dito ay nasa community, 60 po ang nasa healthcare facilities, and around 20 naman po yung ating nasa bilangguan o yung mga prisons. So this is the COVID-19 daily situationer. Aside from the case bulletin na ina-announce po nila every 4 p.m., ito nire-release naman po ng DOH every 8 p.m. So same lang din po yung laman, pero ito po mas comprehensive, mas marami po siyang laman. Makikita rin po natin yung mga same na information na nire-release nila every 4 p.m. So for the epidemic curve, as you can see here, yung nasa taas po, yun po yung confirmed cases. As we can see here, tumataas po yung bilang over time ng ating confirmed cases ng COVID-19. Pero dapat ba mag-worry tayo doon? Mamaya, mas maintindihan po natin siya na hindi lamang dapat po epidemic curve yung tinitignan natin. Dapat tinitignan din po natin yung testing capacity, yung testing strategy, at kung sino-sino po ba yung mga tinetest natin for COVID-19. Para po mas maintindihan natin kung talaga bang worse yung nangyayari sa Pilipinas. Ito po nasa baba naman, ito po yung confirmed deaths by the date of death. So ito po yung bilang ng mga namamatay every day. So as we can see here, during the earlier stages of our pandemic, mas marami pong namamatay. Tapos medyo nag-flatten po siya. Tapos ngayon consistent po na above 20 people yung namamatay every day due to COVID-19. Also, the epidemic curve, pinapakita rin po nila by island. So we can see here for the confirmed case, ito po ay sa NCR, ito naman po sa rest of Luzon, ito po for rest of Visayas, and ito po ay para sa Mindanao. Also, pinapakita rin po ng DOH yung breakdown ng cases by age and by sex. So, I think medyo hindi natin siya na-appreciate kapag nandito po sa table. So, meron po silang ginawang chart. Dito po, dito po muna tayo sa left. Ito po yung case counts. Ibig sabihin, bilang ng positive. Makikita po natin yung color blue, yun po yung para sa lalaki. Yung color pink, yun naman po yung para sa babae. Anong pwede nating maging careful assumptions dito, no? Almost same lang, yung na i-infect na bilang ng lalaki at babae. Pero kung titignan natin, dito po sa age group, mas marami pong na-i-infect na younger population o yun po yung ating economically active na population. Bakit po kaya? Pwede po nating maging careful assumption dito kasi sila po yung ating working population. Sila po yung mas lumalabas, sila yung mas nakikipag-socialize, papunta sa work, pauwi sa work, meron pa silang close contact sa bahay. So most likely po, sila po yung mas nagkakaroon ng symptoms and most likely na matetest for COVID-19. For the deaths naman po, titignan po natin, mas marami pong carefully assume na mas marami pong namamatay na lalaki compared sa babae. At kung titignan po natin yung age group, mas marami pong namamatay na younger or older? Opo, older population. Bakit po kaya? Kasi ito po yung mga population na mas vulnerable, particularly the senior citizen, mas marami po silang comorbidity, meron po silang mga current na sakit. Kaya po we can carefully assume na mas maapektuhan po sila in terms of death ng COVID-19. Also, pinapakita rin po ng DOH yung comparison po natin with other countries. When it comes to case counts, as of August 23, 187,000 po yung infected sa atin. Sumunod po si Indonesia, si Singapore, Malaysia, Thailand, and Vietnam. Sa recoveries po, mas marami rin po tayo. Pero kung bilang ng deaths, mas marami po si Indonesia kaysa sa Philippines. Ngayon, meron po bang sense na nagko-compare tayo ng situations per country? Personally po, kung ako po tatanungin, may mga bearing siya, syempre, para makita natin kung effective ba yung strategy natin. Pero again, no, hindi po pwedeng case count, death count, and recovered counts lang po yung ating pinagkukumpara. Kasi pwedeng yung testing strategy natin dito, for example, very different sa testing strategy ni Indonesia. Pwedeng yung testing capacity natin dito, very different sa testing capacity ni Thailand. Pwedeng yung kung sino bang priority nating i-test dito, kung ilan yung bilang ng laboratories natin, pwedeng ibang-iba doon sa situation ni Singapore or ni Vietnam. So dapat maging careful po tayo, tignan din po natin yung other indicators. So right now, according to the Department of Health, meron po tayong 84 RT-PCR laboratories. Sila po yung nagko-conduct ng RT-PCR test. Later, mas maintindihan niyo po to siguro po sa testing and diagnostic na webinar. Meron po tayong 27 gene expert laboratories at meron po tayong 92 laboratories applying for license to conduct RT-PCR testing. And currently sa 92 na to, 75% po yung nasa stage 3 na po ng application for their license. This picture, isa lang po siya sa hindi po ito yung complete, pero ito po ay ilan sa listahan ng lisensyadong pwedeng mag-conduct ng RT-PCR testing for COVID-19. Also, pinapakita rin po ng DOH yung ating healthcare utilization on the national level and some regional level, kagaya po ng NCR. For example po ito, 26% ng ating bed capacity ay currently occupied ng mga COVID-19 patients. National po ito lahat. ICU beds po natin, 49% occupied. Isolation beds, 47% occupied. Ward beds, 50% occupied. Mechanical ventilators, 29% occupied. Ngayon, every time na pinupost po ito ng DOH, nakikita po natin doon sa comment section na please provide disaggregation by region, disaggregation by cities, pwede nga pong disaggregation by hospitals kasi marami po tayong nakikitang event signals na ito pong hospital na to hindi natatanggap ng ICU patients, itong si hospital sa ganitong city, punong-puno na yung kanilang COVID ward, hindi na sila tatanggap. So sana po nakikita din po natin yung sitwasyon talaga ng mga hospitals by providing more data about the situation of the healthcare utilization in these hospitals, particularly in the National Capital Region, kung saan nakafocus po yung mga COVID-19 patients. Also, pinapakita rin po ni DOH yung ating healthcare utilization rate by the PPE and other health equipment na dinistribute po nila sa different healthcare facilities and hospitals and also to our frontliners. Pinapakita rin po, dito po makita po natin sa right, itong picture na to, yung mga foreign and local donations na binigay sa atin para po tumulong po doon sa ating COVID-19 response. So meron po dyan from Brunei, from Shanghai, from Korea, at Singapore, different countries. Nasa Facebook page po siya ng DOH. Also, unfortunately po, pinapakita rin po ni DOH yun pong healthcare workers na naapektuhan ng COVID-19. So this is the magnitude. When we say magnitude, ito po yung bigat or yung burden na binibigay ni COVID-19 doon sa ating healthcare professionals. And bukod pa po doon, kapag binibigyan niya po ng burden yung ating health professionals, directly naapektuhan din po tayo kasi kung magkakasakit si isang nurse or si isang doctor or kung may mamamatay man po, syempre, bawas po yun sa health force na pwede pong mag-alaga sa atin, na pwede pong mag-prevent ng pagkamatay din po natin bilang mga normal citizens. So currently, meron pong 2,269 nurses na infected ng COVID-19. 6 na po ang namatay. Meron pong 1,368 doctors na infected ng COVID-19. 26 na po sa kanila ang namatay since March. Kung titignan po natin dito sa case fatality rate, 1.9% po ang case fatality rate natin for physician. Pag physician po, doctor po yun. Meron po kasi mga pulis na nalilito kung ano po ang physician, hindi daw po yun doctor, no? Kailangan daw po nakasulat sa lisensya, doctor. So yun po, clarify ko lang yun. 1.9%. Ano ibig sabihin nito? Ang current case fatality rate po natin is 1.55%. Ibig sabihin, mas mataas po mas likely ng mas mataas yung case fatality rate or yung chance na mamatay si doktor sa COVID-19 compared sa general population. This is the epidemic curve po for the healthcare workers only. Kung makikita po natin dito, March to April, di ba? Kita po natin March to April. Dito po yung buhos talaga nung infection para po sa ating epidemic curve. Kung mare-recall po natin, yung mga events na nangyari during March and April, ito po yung time na kung saan nagko-call yung different hospitals for donations ng PPEs, for donations of other hospital equipment para labanan yung COVID-19. So dito po, kaya po we can carefully assume na ito po yung ilan sa mga rason kaya mas maraming hospitals po, mas maraming healthcare workers yung mas na-infect po ng COVID-19. And across time, very steady po na yung nai-infect na healthcare workers for COVID-19. Around 30, that's 30 to 40 healthcare workers every day na nai-infect po ng COVID-19. So that's the overview of the COVID-19 in the Philippines. So let's carefully define some epidemiological terms, give local context and critical analysis on these epidemiologic terms. So first, the very basic, kasi marami pa rin nalilito dito, di ba? For COVID-19 suspected case, severe acute respiratory infection, plus hindi ka pa na-test, pero naka-line ka na for testing. Ibig sabihin, nakapunta ka na sa POE or point of entry that is a healthcare facility or hospital and ready ka na to be tested po. For COVID-19 probable case, ito naman po yung may mga severe acute respiratory infection plus test result inconclusive or waiting for the result of their COVID-19 test. Kasi as we all know, medyo matagal po yung RT-PCR result, especially when you're not a VIP, di ba? Especially kung hindi ka politician, ganun. So kung probable case ka po, medyo nasa limbo ka, hindi ka sure kung positive or negative ka. For COVID-19 na confirmed case naman po, RT-PCR test lang po yung binibilang natin for COVID-19 confirmed case. For recoveries, dati naalala ko pa po nung nasa National COVID Response ako, 2 consecutive results of RT-PCR test yung kailangan mo para ma-count ka as recovered. Pero recently po, this is as recommended by the World Health Organization and the CDC of the United States, time-based tagging na po tayo ng recoveries. Later, we'll touch on this deeper when we go to the mass recoveries or Oplan Recovery of the DOH. For the deaths, these are the confirmed COVID-19 death dying of COVID-19. So let's define mass testing, no? But first, let us go through to this event. So nung March po, early during the ECQ, there was a controversy that VIPs, especially politicians, were getting tested for COVID-19 and bypassing the DOH protocols. Dati po kasi hindi ka matitest kung wala kang close contact or kung wala kang symptoms. Pero these politicians, nakakapag-test po sila. On April 4, DOH announced that mass testing should not be targeted and we should prioritize only persons under investigation. So yung PUI pa po yung ginagamit natin noon. Pag PUI po, meron kang symptoms, 'di ba? Meron kang sintomas ng ILI or SARI or plus meron ka pong possible exposure. Pag possible exposure po nung April pa, meron kang close contact with contact with a positive case or meron kang travel outside Philippines in the last 14 days. Pero po nung June 11, later, with the increasing test capacity, DOH included the asymptomatics to be tested for our COVID-19. So dito po, nag-call po ng mass testing dito. We have to be careful with the term mass testing kasi iba-iba po siya per bansa. Kuwari dito po sa Pilipinas, marami pong nagko-call for mass testing pero yung authorities, palagi nilang sinasabi na hindi applicable yung mass testing sa Pilipinas kasi we can test the 110 million Filipinos. Kasi po sa China, for example, ang definition po nila ng mass testing is to test the entire population po talaga. Yun po yung ina-apply siguro nila Harry Roque and nung ating government dito sa Philippines. Pero pag pumunta ka po sa ibang bansa, for example, you go to New Zealand, the definition of mass testing there is testing the people with symptoms, testing the asymptomatics, testing the frontline workers, testing those who are at the borders, especially the border nila sa mga airports, sa mga yung gilid ng island. Tinetest din po nila yon routinely. And also, regardless kung may symptoms ka or wala, tinetest ka rin po nila. So that's their definition. And in the Philippines, ilang beses na po natin inoperationally define yung mass testing po natin na to test the frontline workers routinely, to test the asymptomatics, as long as you have epidemiologic link. When we say epidemiologic link, meron kang possible exposure that is pwedeng na-expose ka sa isang positive case or meron kang travel outside the Philippines. Plus, test the high-risk communities plus the high-risk population. So yun po yung definition po natin ng mass testing. So wag po tayong malilito sa mass testing is to test everyone. Ganun po siya. Next is the flattening the curve. So the official epidemiologic definition of flattening the curve is delaying and lowering the peak until a point that it is manageable by the healthcare system. So dito po ulit tayo, may timeline tayo. During the ECQ days noong April, DOH Secretary Francisco Duque and some government experts, these are public health experts, assessed that the Philippines has flattened the curve. May mga sources po tayo niyan, hindi ko po alam saan napunta. During the same time period, ncoronavirus.org showed projections and claimed that the Philippines is not yet flattening the curve. However, cases continue to arise, and when the lockdown measures were lifted on June, the cases rose exponentially and majority are aggregated in the national capital region. So for us to understand what is flattening the curve, ito po yung horizontal line, ito po yung ating healthcare system capacity. Yun lang po yung limit ng ating healthcare system. Yung pula, pag wala po tayong ginawang protective measures or preventive measures for COVID, aabot po tayo in such a point na ma-overwhelm po natin yung ating healthcare system capacity. Mas marami po yung severe cases kaysa po sa ICU beds natin. Mas maraming nangangailangan ng ventilators kaysa sa number ng ventilators. Mas maraming nai-infect na healthcare workers. Mas maraming mamamatay due to COVID-19. Pero pag nag-employ po tayo ng protective measures such as social distancing, mask, face shields, some lockdowns, hindi po tayo aabot doon po sa ating healthcare system capacity. This is from CDC. Ito naman po ay from coronavirus and coronavirus.org. And ito po yung ating curve right now. So as we can see, hindi po siya talaga flat. Pero yung question po, is flattening the curve enough? Yun lang po ba yung dapat na call natin? Pero according to international epidemiologist Eleanor Murray of Boston University School of Public Health, that's just one part of the equation. We also have to raise the bar and reduce the baseline. So ito po, GIF po to, pero hindi ko po alam paano magpasok ng GIF sa PowerPoint. Kung wala po tayong gagawin, ma-overwhelm po yung ating healthcare system. That's one. Pero po sa two, kung i-apply po natin yung mga preventive measures such as social distancing, testing, mask wearing, we can flatten the curve. Pero mababa pa rin, mataas po rin po siya sa ating healthcare system capacity. So kailangan po natin na i-increase yung ating healthcare system capacity. Yung horizontal line, iaangat lang po natin siya. Paano po? Mag-provide po tayo ng mas maraming healthcare workers, palakasin po natin yung ating mga hospitals, paramihin po natin yung ating mga hospital beds and ICU beds and mechanical ventilators and other hospital equipment na kailangan for COVID-19. And aside from this, alagaan po natin yung ating mga healthcare workers, yung ating mga nurses, yung ating mga doctors, and peripheral hospital workers para po mas maging motivated po sila sa paglaban po natin sa COVID-19. And lastly, reduce the DOH demand or hospital demands. Ibig sabihin lang po nito, kung hindi naman po emergency yung ating mga sakit, kung hindi naman po urgent yung ating mga sakit, baka po maaaring hindi po tayo pumunta sa hospital muna para po mas makapag-focus po yung ating health force doon po sa mga COVID-19 patients at doon po sa ating mga emergency na events or ating mga pasyente. So ito po, flatten the curve, raise the bar, reduce the baseline demand. Next po, punta tayo sa epidemic curve and waves. First wave, second wave, third wave, tertiary waves, or whatever number of waves pa yan. It is an uproar. Nagkaroon po ng uproar occurred when DOH declared that the Philippines is on the second wave of infection. Many experts clash and disagreed on this. So majority of the contention revolves around whether to consider the 3 cases, yung 3 kanina, yung Chinese national plus yung dalawa pong na-infect noong March 6, yun na daw po yung first wave, di ba? Pinag-aawayan po yun at some point in time. But we have to realize that COVID-19 pandemic waves are continuous and there will be more waves even after the current wave na nandito po tayo. Just to discuss it more, para po dun sa tatlong case, para po maklarify natin siya kung first wave ba siya, di ba? Ito po ay from CDC. And this is the epidemic curve, and this is the stages of or strategy po doon po sa ating epidemic curve. So as you can see here, we have the pre-pandemic intervals, we have the investigation. Kailangan mo po kasi mag-conduct ng outbreak investigation muna bago mo masabing may outbreak ka na ng kahit na anong sakit po ito. Next is the recognition. Pag meron ka ng evidences na meron na nga po nung sakit dito, kailangan mo na siyang i-recognize at mag-prepare for the initiation of the wave, the acceleration of the wave, and you have to, at atong goal mo dapat ay for the ma-decelerate yung wave na to. Now, bakit preparation po itong isa? Kasi you have to prepare for the second wave, for the third wave, and for the tertiary waves. Kasi inevitable po siya eh. Hindi po siya what if eh. Hindi po siya more on what if. Mas ano po siya, mas ang tanong dapat is kailan siya mangyayari and prepared ba tayo kung mangyari man siya. So stochastic events are considered part of the pre-pandemic wave. This is more on the recognition. So for me po, yung 3 cases po natin noong January, masa recognition part po siya at part po siya ng pre-pandemic interval for the first wave. So, let us further ask ourselves, second wave na ba talaga tayo? This is Tokyo, Japan. This is Victoria, Australia. This is New Zealand, and this is Philippines. This is the first wave of Japan, and this is their second wave. This is the first wave of Victoria, Australia, and this is the second wave. This is the first wave in New Zealand, and after 101 days of not reporting any local transmission, August 11 na pick up po nila yung index case nila or unang case for the second wave. And this is the epidemic curve for the Philippines. So you can graphically analyze kung meron po ba talagang first wave and second wave po dito sa graph na to. So next is the backlogs po. We have 2 types of backlogs, the testing backlogs and the verification backlogs. So for the testing backlogs, ito na po yung mga na-collect na specimen. Na-collect na po yung specimen nila for testing pero hindi pa po natitest dahil sa logistic reasons such as overwhelming the testing capacity or hindi po available yung material o pwede po nag-close down yung laboratory kasi may na-infect po silang worker doon among other reasons, no? And then we have the verification backlogs also. These are the cases that are COVID-19 positive. Mamaya ito touch po natin to ng mas deeper. Ito po yung mga cases na nag-positive na pero not yet included in the confirmed case of the DOH. Kasi po i-check pa nila kung talagang individual ba to or duplicates lang ba to or may problem ba tayo sa data management. So let's check on backlogs, di ba? So as of August 23, ang confirmed case po natin 187,000. Pero ang positive po natin for COVID-19 ay 226,000 na po. Ibig sabihin, yung difference po, yun pa po yung hindi na-verify. 39,000 cases. 39,000 cases as of August 23, yung pending, kung confirmed case ba sila or hindi confirmed kahit na nag-positive na sila for COVID-19. And we can see in this chart, this is visualized by Dr. D and Dr. Kaiton of the COVID-19 Pandemic Response Team. As we can see here, across time, mas tumataas po or dumadami talaga yung bilang ng mga kailangang i-verify. Ito po yan, di ba? Ito po yung difference. Sabihin, dumadami po siya over time. And yung peak niya po, noong pong early August, 47,000 cases po yung dapat i-verify kung confirm ba talaga. Nakalito po no kung confirm and positive. Pero confirm po yung ginagamit natin. And the latest po, ito lang August 24, 41,000 po yung kailangang i-verify na positive cases kung confirm po ba sila. But kahit na nakikita po natin itong mga backlogs na to, according to DOH, wala na daw pong gaps, wala na daw pong backlogs na kailangang i-verify doon po sa ating COVID-19 confirmed cases. So on June 1, they reported na wala na daw pong backlogs. This is a screenshot from the ABS-CBN News. Also on August 19, they said the same thing na wala na raw pong backlogs in COVID-19 test results. This is a screenshot from the Philippine Star. Next is the mass recovery. So ito po yung pinaka recent na Oplan or program ng DOH, COVID-19 response. This is the Oplan Recovery. So DOH decided to adopt the WHO CDC recommendation of using the time-based recoveries or Oplan Recovery. So on July 30, naalala po ba natin na nag-report po sila ng 38,000 recoveries in a single day. On August 16, nag-report na naman po sila ng 40,000 recoveries in a single day. So ito po yan, nung July 30, naging 22,000 na lang po yung ating active cases kasi on that day, 38,000 po yung na-report na recoveries. So this is really weird, no? Kaya pong gumawa ni DOH ng program or Oplan Oplan Recovery para po i-validate yung mga kung recovered na ba yung mga patients. Pero kanina po, yung kaninang backlogs na 41,000, hindi po magawa ng program or hindi po mapabilis yung pag-verify kung confirmed case po ba yung mga positive cases na to. On mass recovery, this has been heavily criticized by independent data analysts and as a result, DOH will report every Sunday, bukas po yung next na mass recovery natin. They will report every Sunday yung mass recovery po natin. So paano po ba siya nangyayari? Ganito po siya. So on Sunday, sa dashboard po ng DOH, hanapin po nila yung mga mild and asymptomatic patients na yung onset of disease nila or yung test results po nila is more than 14 days na. Ipipick up po nila itong mga to and Monday to Friday, i-report po nila to sa ating CESUS or CT, Epidemiology and Surveillance Units, at i-verify naman po ng ating CHDs or Centers for Health Development plus the CESU to the LGUs kasi LGU na po yung naghahawak ng ating contact tracing, di ba? And monitoring of our cases na naka-home quarantine. I-check po nila kung totoo po bang recovered na itong mga to. And then by Saturday, Sunday, isesend po ni LGU plus ni CHD back yung mga list na yon to DOH and DOH will DOH will conduct the final data quality check and logic check. Tsaka po nila babaguhin yung tag mo doon po sa system. So kapag verified pong recovered ka, magiging recovered ko po talaga. And yun po yung na-report every Sunday 4 p.m. na 38,000 and 48,000 na recovered. But Dr. Jomar Rabahante of the Biomathematics Research Team continually tracked the changes in the status of patients from April to July. So 24 patients changed from asymptomatic to dead, 943 cases changed from mild to dead, and recently lang po itong Tuesday, ni-report po ni ABS-CBN, di ba, na yung 4,396 cases doon sa mga recovered ay duplicates po pala. Plus, meron pong 309 deaths na nireport po nila as recovered. So meron po talagang problem doon po sa Oplan Recovery na part. Kailangan po nating malaman kung saan po doon nagkakaroon ng problem para po maayos po natin yung ating reporting system. Next, last two na po ito, reproductive number. We have two. We have the basic reproductive number. Ibig sabihin lang po nito, kung ito po yung bilang ng tao na may infect mo. Kung meron ka pong isang infected individual, ilan yung may infect niya. So makikita po natin minsan sa basic reproductive number and even in the time varying reproductive number, pag more than 1 po siya, ibig sabihin mas may chance na maka-infect ka ng more than 1 person kung infected ka. So ang goal po natin is maging less than 1 po yung ating reproductive number. For the positivity rate naman po, ito po yung diniscuss ko kanina. Positivity rate, ito lang po yung bilang ng individuals na nagpa-positive sa number ng mga tinest natin. Again, kung may 100 test po tayo today, 5 po yung nag-positive, meron po tayong 5% positivity rate for today. So ito po ay analysis ni Dr. Peter Kaiton of UP Research Team. Tignan po natin yung RT natin or yung reproductive number. It's 1.006. It's still above 1. Ibig sabihin, mas nakaka-infect ka pa rin po ng more than 1 person or 1.006 person when you are a COVID-19 positive. And then we have this positivity rate, di ba? Across time, makita po natin, naglalaro lang po siya between 5 to 10%. Ibig sabihin po, sa 100 pong natetest, yun nga, 10 po, more than 10 po yung nagpa-positive. But we have to be careful when we are analyzing positivity rate po, no? For example, I'll give you an example. In Guam, sa Guam po, it's a Pacific island in Guam, meron po silang positivity rate na 100%. 4 days po yun. Bakit kaya? Ibig sabihin po kasi, nung chinek po nila yung data management, yung data nila, ibig sabihin, meron pong mga days na nag-test lang sila na 3 patients. So, 3. At yung 3 po yun nag-positive. So, 3/3, that is 100% po, di ba? Ibig sabihin, 100% po yung positivity rate nila on that day. So, we have to be careful when we're analyzing the positivity rate. last three na pala. So we have the case fatality ratio. This is the number of COVID-19 deaths over a total number of confirmed cases. So mga confirmed cases, ilan po yung namatay? But this is really not reliable during a pandemic. And we have the CDT and MDT, or the case doubling time and the mortality doubling time. So ito lang po yung oras or yung days po siya, sorry, para magdoble po yung cases po natin. Or for mortality doubling time naman po, para magdoble po yung deaths po natin. This is useful po, no, in the earlier stage of a pandemic. Pero po ngayon, bakit po kaya hindi siya useful? Kasi po, sa libo ba naman, di ba? Imagine mo 200, at we are at 200,000 na ngayon. Siyempre po, logically, mas mahirap na pong doblehin yung 200,000 na infected, na COVID confirmed cases kumpara ng mga earlier stage na meron lang po tayong 3, 4, 10, mas madali po siyang madouble. So next, this is the DOH bulletin. So we have the case fatality rate here. Global daw po yung case fatality rate 3.4, pero sa Pilipinas 1.55% lang. For the positivity rate, globally it's less than 5%, but in the Philippines it's 10.50%. And for the reproductive number, globally it's 2 to 3%, and nationally meron lang po tayong 0.86%. This is not consistent with the computation done by Dr. Peter Kaiton, which is na yung RT daw po natin, or yung R0, or yung reproductive number, is 1.006. So when we criticize this, we have to carefully criticize this, no? An RT of 0.064 is still close to 1. And then, sana po, when we're doing this, we have to show the 95% confidence interval of reproductive number. So what is 95% confidence interval? When we're estimating po, meron po tayong point estimate and interval estimate. Pag point estimate, ito yung number, yung bibinigay ko na. Pero kapag meron po tayong interval, pwede po nating sabihin na our reproductive number is between 0.9 to 1.1. Mas accurate po yun kasi mas marami kang napapasok na values doon po sa assumption or estimation mo. Diba? And it's too early to say na we are faring better with other countries, and we have to also look at other indicators. Hindi lamang po sa reproductive number yung mga faring better natin, yung case fatality. We have to look into the different situation in countries. We have to check the type of country, the healthcare system capacity in each countries, the health financing in each countries. We have to consider these other indicators bago po tayo mag-compare ng mga numbers na to, especially globally. Globally po, di ba? And then the case fatality rate is unreliable during a pandemic according to the World Health Organization. And then faring better or faring worse should be interpreted with caution. We have to, yun nga po, we have to be careful lagi. Kasi we're sending messages to the public eh. These are evidences, these are scientific evidences na binibigay po natin sa public. So we have to be careful and we have to be cautious when we're interpreting numbers. Again, I'll just like to show the time varying or the RT computed by Dr. Peter Kaiton and the case fatality. So kung babalikan po natin, our case fatality is 1.55 according to DOH, and according to independent computation, it's 1.6. So they're almost the same, but the time varying is different. According to DOH, it's 0.86, but according to this independent analysis, it's 1.006. And I'd like to show this, no, kasi in public health, we have to consider health promotion and educating the public. Because throughout the pandemic, DOH has changed the layouts of its daily bulletin. Mas nagkaka-confuse po siya, di ba? Ito po, earlier in March, tapos naging ganito. So the next slides, pinapakita ko lang po yung different designs. So medyo confusing po siya kasi unlike other countries na meron lang pong isang template for reporting cases. Actually, it's a dashboard. Mas nakakalito po kapag nagbabago-bago po tayo ng reporting system. And this is the latest summary released daily by the DOH starting August 21. So Personally, I appreciate this kasi makikita po natin, no, ito, intindi ko kagad na ito yung tested individuals and ito yung positivity rate, confirmed cases, ito po siya, active cases, ito po siya, recoveries and deaths. So wala pong masyadong arte and very straightforward po siya and mas naiintindihan po natin. So I'm not really a policy making person, but I'd like to touch on this para makita po natin yung use ng epidemiologic data in COVID-19 policy making or interventions making. So pwede pong i-integrate natin yung mga numbers na to sa ating response framework. So application of LGU, of the LGU epidemic response framework. So ito po yung epidemic phase, recognition, initiation, yung diniscuss po natin kanina, acceleration, deceleration, and then preparation. The risk level, ibig sabihin po nito, gaano po ka-risky itong mga phases na to. So for recognition, medyo low po siya kasi kaka-recognize mo pa lang na may virus, 'di ba? Initiation, yung nag-start na po yung virus, medyo moderate. Acceleration, tumataas po yung ating epic curve. Ito na po high siya. Deceleration, moderate kasi napapababa po natin yung ating cases. And then kapag nag-low, hindi ka po dapat mag-relax. Dapat mag-prepare ka for the secondary and tertiary waves. For the strategy, we have to do containment, we have to do mitigation, we have to do enhanced community quarantine, we have to do general community quarantine, and we have to do preparation for the next phase or the next wave. And aside from this, I can't really find a document, public document na, kasi I'm not sure if pwede kong i-share dito yung sa work ko, right? Pero kunwari, for example, sa Japan and then other countries, kunwari, they have these indicators po talaga as in nakalista, and then they have the stage assessment, the transmission assessment, and then dun po sila nagde-decide kung ano po yung, for example, their testing capacity. This is the number of testing capacity. And then they compute everything, they analyze everything, and then dun po sila nagde-decide ano yung dapat nating gawin sa mga ganitong numbers. Ano yung mga policies na dapat nating ibigay sa ating community sa mga ganitong numbers natin? Ano yung mga interventions na dapat nating i-apply para mas ma-prevent natin yung COVID-19 at ma-maintain yung mga good numbers na to kung good man sila. So ito lang po yung diniscuss ko kanina. Same siya, recognition, initiation, acceleration, deceleration, preparation. So some reminders before I end my presentation. Remember 3 W's. This is from the WHO. Wear mask, wash hands, watch your distance. Akala po natin wala itong tulong, no? Pero as public health, since public health is public health affair, lahat po tayo may contribution, lahat po tayo may responsibility for COVID-19 mitigation and negative effect mitigation. So we have to understand these 3 W's, very helpful po talaga siya. Avoid 3 C's, crowded places, close contacts, and confined or enclosed spaces. Ito rin po kailangan din po nating matandaan. Ito po yung pinaka-mako-contribute po natin sa ating COVID response. And I'd like to acknowledge these people who helped me with this presentation. Dr. Louis D is a postgraduate intern at the Philippine General Hospital. He helped me with the compilation of this presentation. He is independent data analyst. Dr. Paul Adrian Pinlac, epidemiology professor. Professor Kim Carmela ko, public health epidemiologist. I use some of their slides para po dito. Dr. Peter Kaiton and Joe Marabahante and Dr. Eleanor Murray of BULSU, Boston State School of Public Health, Boston University School of Public Health. I use some of their analysis and interventions para po dito sa presentation na to. And of course, the Philippine media outlets, Google, DOH, and WHO websites, yung mga graphs na nakikita po natin. So thank you everyone for your attention. Thank you for listening.
Thank you po, sir.
Thank you, Mr. Lorenzo. Thank you po sa very fruitful na discussion about the epidemiology of COVID-19 virus po. So I hope everyone learned a lot about Mr. Carlo Lorenzo's discussion. So sana magamit po natin yung knowledge natin, no? Yung mga terms na tinuro sa atin ni Sir Carlo po. So, ayun, we are now opening the floor for discussion. If you have any questions, you may send your questions through the chat box. So, ayan, so medyo marami tayong question ngayon.
Oo. Ito, first question
Natin
from
kay
Miss Nadine Putian. First question, Sir Carlo. For the daily positivity rate of testing, do these tests include rapid antibody testing or purely RT-PCR lang po? Thank you.
Okay. I think mas madidiscuss siya later sa ating diagnostic and testing part. But I to answer this, the positivity rate, ito lang po ay ang ating confirmatory test. Pag sabi ng confirmatory test, doon lang po natin malalaman kung COVID positive ba ako. RT-PCR lang po yung ating ginagamit. So for the rapid antibody, it is highly discouraged by public health experts and clinicians in different hospitals and even the Department of Health because it is not accurate, it has less sensitivity, it has less specificity, and I think, please correct me, I think kunwari, meron kang 5 COVID positive patients, isa lang po doon yung true positive or yung nadedetect po talaga ng ating COVID, ng ating rapid antibody test. So that's it. It's purely RT-PCR po.
Okay, thank you, sir. Actually, that answers also the next question, which is, kasama ba sa COVID-19 confirmed case yung mga positive sa rapid test, which is no. Now,
I'd like to touch on this question.
okay.
Anong ginagawa mo? Kasi, di ba, parang kalat na eh. Ang dami nang gumagamit ng rapid antibody test na yan. Because it is cheap, di ba? It is mabilis po naman, di ba? It is very accessible. Kaya ko kagad kumuha ng test na to. And it's cheaper compared sa RT-PCR which costs 4,000 to 8,000 pesos since it's not free. So mas marami po talagang gumagamit nito. With this, kapag nag-positive po kayo dito, but I don't encourage anyone to use the the rapid antibody test ha. Pero kapag po nag-positive, dati kasi ang ginagawa, I'm not sure if ganito pa din. Pag nag-positive ka sa rapid antibody test, you can use this para makakuha ng RT-PCR test. Ginagamit parang you can show it to your physician na nag-positive ka sa ganito. Pwede po ba akong makapag RT-PCR test? Dati po yun, I'm not very sure kung ganun pa rin po yun nangyayari ngayon.
Okay, thank you, sir. Another question from Mr. Ramon Dichoso. Bakit po nagkaka-duplicate ng numbers pagdating sa cases? Yun po.
That is really a sensitive question. I'm not really sure, but this can be an issue in different offices. Of course, we don't just blame the Department of Health data management team on this, but there has to be a flaw in the system, di ba? Kasi the data goes to different institutions. For example, from the point of entry from hospitals, pupunta yan sa laboratories, pupunta yan sa CESUS, pupunta yan sa LGUs to do the contact tracing, and then babalik ulit sa DOH. So, doon po sa ating process flow, meron po sigurong flow doon na hindi po natin ma-pinpoint, and I hope ma-pinpoint na po siya very soon para po makapag-report na po tayo ng very accurate data. Yun po, may problem po doon sa ating process flow, and I cannot pinpoint kung saan po siya problematic.
Ayan. Thank you, sir. Another question from Kidney Alonzo. Do clusters determine the specific COVID-19 hotspots? And does the DOH and other health institutions utilize it while strategizing preventive measures?
Okay, so when we talk about clusters, as I said a while ago, these are 2 or more aggregated cases in the same place at the same time, diba? Or sa time interval na to. For the hotspots, I don't think different definition na naman siya, different operational definition na naman siya per country. But I'm not really familiar right now with sa Philippines kung consider ba nilang hotspot yung clusters. But what I know is the DOH and other health institutions, ginagamit po nila to, yung information po natin with the hotspots. For example, we just to give an example, nasa GCQ po tayo ngayon, right? And the DOH recognized another cluster, another hotspot in, for example lang community in Manila or a certain barangay in Manila. Then you can impose a more strategized preventive measures there by implementing a ECQ or lockdown, total lockdown of that barangay. Kahit na naka-GCQ tayo ngayon. So yes, they're using this information for preventive measure strategies.
Okay, thank you, sir. Isa pang question from Royce Chua. Okay, medyo sensitive rin natin ang question na to. How transparent are the data presented by the DOH?
I think when it comes to transparency, it's yes, sensitive, but we have to recognize the issue of transparency, di ba? Just because it's sensitive doesn't mean na dapat hindi siya pag-usapan. There has been many called by many independent epidemiologists, many independent biostatisticians, many independent institutions calling for open data from the DOH, not just the data drop, but also provide the data on COVID-19, include all the necessary variables para po mas ma-analyze, magkaroon po ng proper analysis yung mga independent institutions po natin na gumagawa ng independent analysis on this COVID-19 data. Also, with the open data, mas may ensure po natin yung scientific collaboration. Let us face it, walang perfect, walang pinakamatalino, walang monopoly of the knowledge of epidemic and pandemic response. There are different experts na we can say studied abroad, have PhDs, and can give something to the table. So if we do an open data and scientific collaboration, mas makakapag-produce po tayo ng mas sensible, mas comprehensive, mas humane na response to this COVID-19 pandemic.
Yes, tama. Tama na dapat erase talaga natin yung transparency pagdating sa mga data na to. Ano ba yung sabi nila? Better to know the hard truths than blissful ignorance, sabi nga nila. So, next question from Kiara Inco. Paano po nagsisimula yung second and tertiary waves?
Actually, this is more this is a very technical question. Thank you for raising this. Some epidemiologists says that we can't use first wave, second wave, tertiary waves because it is a continuous wave. Hanggat may COVID, continuous wave po yan, di ba? We have to be very careful. But to answer your question, yes, we can use secondary and tertiary wave. Pero paano siya nagsisimula? Let me give you an example. For example, in New Zealand, di ba? They reported 0 local transmission cases for 101 days, which is very impressive. And then on August 11, they detected 4 cases of locally transmitted cases in their country. So, paano siya nagsisimula? We can, ang pwedeng sagot po natin dito is the testing strategy. Who are they testing, di ba? Who are they focusing more? There has been issues in New Zealand na I'm not sure, but these are not verified information na some of the border staff hindi sila nabibigyan ng routine testing and they are the ones facing yung mga umuuwi from different countries, yung mga repatriates nila nakakasalamuhan ng mga borders na to. And after the day, they go home to the community, they go home to their families, and they raise the issue na hindi sila natetest. So maybe kung hindi natin na-detect yung mga, kung nasiskip natin yung population na yun, kung nasiskip natin yung mga essential workers natin, kung nasiskip natin yung mga dapat nating itest, magsisimula po talaga yung ating tertiary and secondary waves.
Thank you, sir. Okay, another question from Angelica Kiamco. Kasama po ba sa counted deaths ng DOH yung mga namatay na recovered?
Oh, I have to check on that. I'm not really sure. That's a good question. If nag-recover ka na and then namatay ka, yes, that's the question, right? I have to go back on that. Thank you for raising that. But personally, I think hindi siya kasama kasi recovered ka na eh. But let me clarify on that. I'll get back to you.
Okay, thank you. From Sherwin Dale Egges, is it necessary na RT-PCR if nag-positive sa rapid test knowing that the latter is not that accurate? I think, okay, sige, sir.
Um, yes, so, kasi inaccurate yung rat, di ba? Tapos nag-test ka noon, tapos pero positive ka, and then, okay. For this, siguro, I think yes, you have to, kung nag-positive ka sa rat, I think siguro, it's a case-to-case basis. For example, bakit ka ba magrarat? Kasi you're feeling, you have symptoms, di ba? You're feeling, you had a close contact with this person. So, you have to assess them, you have to check on your physician, you have to ask them if dapat ba magpa-test ako kasi dapat ma-assess nila yung health mo before providing you a prescription or a what do you call that? Recommendation na mag-RT-PCR.
Okay, thank you. And for our last question, sorry kasi may time constraint kasi tayo, from Vince Michael Sabal. With the present data and statistics, what are the best policies or measures not disregarding the present protocols can be suggested and implemented to contain the further spread ng virus?
Okay, I think this is the best question to close this part or this presentation. No? With the current statistics, we're really not doing well. The Philippines, when you compare it to the region, not just in the Southeast Asia, but also in the Western Pacific, we're not doing well. Our transmission level, community level is high. Maraming namamatay. Even with high testing, mataas ang ating positivity rate. Even with expanded testing, mataas pa rin po yung ating positivity rate. It means that meron pa rin po tayong mga hindi na-detect na local community transmissions in our community kahit na expanded po yung testing natin. So what is the most acceptable preventive measures para mas ma-prevent natin to? So we have first is the individual efforts. One is don't be stubborn, please. If sinabing stay at home or wear mask or wash your hands, wear face shield, just do it. It's just a mask. It's just a face shield. It's just staying at home. If you're not working, diba? If you're a student doing you can just stay at home para mas makatulong po tayo dun po sa ating community as a whole. And then second is on the national level or more on the authorities. They have to give us a comprehensive and humane plans. For example, nag-ECQ dati, di ba? I think ECQ, applicable pa rin siya now, pero dapat humane na siya eh. Dapat they have to, kasi kung hindi ka mamatay sa virus, di ba dati, mamamatay ka sa gutom. They have to provide food, they have to provide health security to these people, to the population. They have to give hindi lang siya about COVID, about your health siya as a whole. So I think ang pinakamasasuggest ko to help our frontliners then revert to ECQ maybe 2 more weeks or 3 more weeks or 4 more weeks, but during this time dapat may plano na po talaga from our authorities. Dapat humane po yung treatment natin doon sa ating mga individuals na naka-enhance community quarantine sa kanilang mga bahay. Dapat nagpo-provide ng pagkain, dapat nagpo-provide po ng sahod, dapat mag-stop po yung mga rent kung nagre-renta man po. Dapat we have to be more humane, and we have to recognize na we are in a pandemic, and dapat compassion over anything, over money. Yun po yung dapat na manaig doon sa mga panahon pong ito.
Ayun. Thank you so much, sir. Yung mga iba nating questions, ang dami pang questions actually. Pero since time constraint, collate na lang namin, then we'll send them to sir, then post namin sa page namin yung mga sagot sa mga katanungan nyo. Okay, sir?